Thank you. So we'll
Okay,
start again.
sure, no problem. So we're going to talk about common hand problems, conditions. Again, this is part 2. We spoke about part 1, nerve problems, tendon problems, and bony problems. The ulnar collateral ligament injury or the skier's thumb was a special request from one of the people in the chat, and so we talk about it. So I'm going to start with part 2 now. More of hand surgery rather than medical student and GP's approach for hand conditions, but these are things that I do for hand problems, surgical issues. So this is joint problems. We do see quite a number of arthritis. We don't see them as much as before because we have good rheumatologists to take care of all the RA and prevent them from deteriorating into severe hand deformities. But we do now and then see osteoarthritis like this patient of mine. If I don't remember wrongly, this was quite a while ago. This was when I was still practicing in UMSC. She came with this crooked looking joint in the middle finger at the PIPJ, this joint here. And this was after she developed some injury when she was young. When she was young and developed osteoarthritis, she was in her 60s, I think. So this was a joint replacement, like you can see here. That's a joint. Again, yeah, there's a joint. So we cut off the joint of the. You see quite a number of our knee joint replacement, hip replacement, but hardly any hand or joint replacement in the hand because first of all it's costly and there is some problems with the number of cases that we have. We have very, very small volume, so it is very costly for people to bring in the implants. The company that used to bring them in actually stopped bringing them in for quite a while because there was just the MDA, the cost to register all these implants was just too much for them to want to invest in the registration. So, but lately we have one of the companies did manage to bring it in and do that. But I have not had any operations of the finger joint since this patient that I've done, and you can see here. So you can see this is after the surgery. Her finger is no longer crooked, and that's the before and after. But the range of motion, unfortunately, is not great because the amount of motion of the finger or the joint greatly depends on what was the range of motion prior to operation, rather than the joint can move. Some people think that by replacing it, I can make the joint move better, but that's not the case. It's mainly because you want a not deformed looking finger and not painful finger, painful joint. That's all. Not so much for increase the range of motion. So if you have patients who have good range of motion but then have a lot of pain and problems with pain, then a joint replacement is a good option rather than a fusion. Because before joint replacement, we used to just fuse them and then there will be no more motion at all. So joint replacement is a reasonable treatment option for osteoarthritis of the hand.
So this was done basically for aesthetic reason?
Aesthetic and also some function. I mean, she has pain. So after the joint replacement, she doesn't have so much pain anymore. Yeah, because or else you have pain all the time. Every time you move, it will be painful. But if you can see, aesthetic for sure is much better.
Yes.
So function will also be better because all things like finger like this will get hooked onto stuff and it's crooked, right? So when it's straight like this, the function is a little bit better, and also of course there's no more pain after the joint replacement. But the range of motion, unfortunately, is not increased compared to pre-op. Yeah, so that's the deal with joint replacement of the hand. So other things, we do see skin problems like this, burn syndactyly. So this is a child came to us after being scalded by some hot water in the kitchen. And this is what we do. We do some web space we release the take away the scar, and then we did some flaps to create the web space again for the child, or else the child will not be able to use the hand properly. As you can see here, there's webbing, and the web is no more there because we now create the space. Then we do see some infection, skin infection like this. This is a necrotizing fasciitis. This is actually a colleague's father who came to see us because initially was treated in the emergency as cellulitis. The next morning when I saw him in the ward, there was already a hole, and when we look at this hole there, the whole entire skin underneath is already dead. And this is how it looked like. This is dishwasher type skin, and if you can see, these are dead tissues down deep to the deep fascia. So this is after debridement. You can see all the tendons are exposed, and if you just leave this alone, this is eventually going to get infected, and the patient will end up with an amputation. Before we could do flaps, we just do skin graft, full thickness skin graft or partial thickness skin graft to cover this wound, and all these tendons will get then adhere to the skin graft, and there will be loss of function. But that was not what we did. So we debrided, and then we put him on some sort of specialized dressing. I'll show that in another case. And this is a radial forearm flap, skin taken from the forearm with radial, based on the radial artery. So basically, we take a radial artery along with the whole piece of skin, the full thickness of the skin, and cover this dorsum of the hand, so that the tendons are not exposed and won't adhere to the skin graft. So then,
sorry, what is the underlying predisposing factors to getting this necrotizing fasciitis? Huh?
Usually they are injuries lah. So this patient presented after he's an avid gardener. So he went to his garden, did some gardening, then he knocked his hand against the standpipe, and of course, he's also elderly, like he's in his 80s actually, and he just ignored the small little injury, and that small little puncture or injury is this hole here, and the bacteria just get into the underneath the skin and cause this infection.
Wow.
So a lot of times it's a small little cut, or of course, if you have history of diabetes or any immune system problem, then you are more likely to get into this type of infections. And most of the time, they are diabetics. So, but this patient was not. So that's good.
So if the infection was treated early, it could have been prevented.
Yes, yeah, you're right. So the most of the time, patient present late for things like this. So sometimes there's a penetrating injury that patient didn't notice. So all injuries with signs of infection should be treated aggressively with antibiotics, and sometimes you need to treat them with surgery as well. So this is one of the things that we do to surgically treat this, and you can see there's good motion of the hand. Actually, we could do better than this, but he doesn't want to do any more therapy and stuff like that. So if you can see here, the metacarpal joint is still very stiff. So you can actually get much better treatment outcome if he comes for therapy, but he refused to come for therapy because he said, I have reasonable good function for my hair. I don't want to come for therapy anymore. So
he's back to gardening, I'm sure.
Yeah, he's a tough guy. So other things like severe upper limb injury like this. So yeah, so this is a young lady. She came. She's a vet student then. She's now she graduated since then. So this is her hand. She presented it to the emergency department in a small little clinic kesihatan in Sandakan. And when she arrived in Sandakan Hospital, this was how her hand looked like. So the MO wanted to amputate the hand. There was a foreign specialist then, orthopedic surgeon in Sandakan, but the MO was the one who referred the patient to me and said that this is the patient, and the patient refused and to give any consent for amputation. She's a young girl. She's a very brilliant student. She graduated as a vet, the top of her class, even after this injury. So she had a injury. This is due to farm injury. So she tried to unstuck some hay cutter or grass cutter, and the whole hand went into the machine. And this is the X-ray. You can see the bone is cut in multiple at the metacarpal, carpal, the forearm bones. So the MO in Sandakan, I cannot remember his name now. I have to give him a lot of respect that he managed to do what he could do, and this is how she presented to the emergency room in our hospital when she arrived in UM. Then with all the wires jutting out,
So
some of the skin
the medical officer actually salvaged to this extent.
Yep. So this the story was, I got referred not by I was referred by a colleague of mine who was already in private practice, and said, hey, I have a friend who is working in Sandakan who is an anesthetist, want to refer a case like of such. So I said, okay. So when the anesthetist was the one who called me initially, he said, hey, can you please take over this patient? I said, why is it that you are the one who is referring the patient to me? He said, I'm taking care of this lady in the ICU, and next week I'm going to go off for my Chinese New Year holiday, and I think this patient is going to lose her arm or die in the ICU if I don't send her off. So when they called me, I have no choice but to take her over, and said, okay, we'll see. She's not from Sabah, she's from here. She's not from Sabah. So she flew back to KL, and this is what I saw. And this was the X-rays with all the wires there. Again, you can see this is the skin is dead. All right, it's dead skin. So if you just stitch the skin back, this is what is going to happen, and this will surely end up with an amputation unless we do a proper debridement and then reconstruction to all this stuff that we are looking at. So this was the first debridement. So we took out all sorts of garbage or dead tissues, and these are the tendons that are exposed. The nerve was gone, the artery was gone. Thank God there was just the ulnar artery that was supplying. The radial artery was all gone, or eaten up by infection or injury. So this is a VAC dressing. It's a sponge, specialized sponge with nano silver, impregnated silver in it, and we then debrided. This is then hooked up to a vacuum. So she was put on there's a suction tube. I don't have the photos here, but basically what it does is create a negative pressure, and they suck away all the debris and not the blood and the infected tissues. That was after one debridement. This is the second time I go to theater, about 3 or 4 days later. And this is how the wound looked like. And this is good. It looks horrible, but it's actually very good, because if you compare it to what it was, this is very bad. So this is very good. And we then managed to do this. This is the flap. This is the groin area. This is the thigh. This is the ASIS is somewhere here. And this is a groin flap. So it's a pedicle flap. And we managed to put a SSG on top because the flap was so big. So this is a flap, so it's a pedicle flap. So the hand is attached to the thigh or to the waist for about 3 weeks. After 3 weeks, we take this off. We release the flap, and this is how the hand is like. And this is a year later. If you can see, this is how the hand looked like. Let me see whether I can. There's a video. So that is the function. All right. So if the MO in Sandakan didn't try to salvage her hand, she would have no more hand. It will be, you know.
Okay, can I ask you a question at this
Sure.
point of time?
Sure.
With all this injury, her tendon was still attached.
Yes.
Was
yes.
it?
Most of the tendons were still there, so that's why I didn't have to. I didn't have to repair much of the tendons.
And the arteries was also not affected.
Arteries were one of the radial artery was gone, was thrombosed, infected. God knows where it was when I debrided it, but the ulnar artery was there, and that keeps the hand going. If the ulnar artery was also destroyed or infected, she would have no more hands. Yeah. So the main supply, arterial supply to the hand is from the ulnar artery, not the radial artery. So she managed. The hand didn't die, but of course the soft tissue was very badly infected, and most of the tissue that was injured was dead. So that's why we have to debride it, and then this is what we did.
So if you are the MO that did this case before sending it to Dr. Teh, we would like to congratulate you. Or if you know of the MO, please congratulate.
Yeah,
Yes,
he actually
well
did a
done.
very good job for a very junior MO to try to do what he could. I cannot remember his name now. So yeah.
Okay,
so
great.
other complex injuries, more complex injuries. All right. So this is a severe elbow trauma. This guy fall off his motorbike. This is a road rash. This is the elbow. This is the arm. There's the forearm, and this is the elbow area. If you can see, all this skin is gone. Not only is the skin gone, after debridement, you can see that's the joint. That's the elbow joint. And there's no more nerve. So the ulnar nerve is gone. So you can see the medial the medial epicondyle is gone. There's no more bone here. The normal medial epicondyle is like this. So there's no more medial epicondyle. Part of the ulnar is also gone. So the medial side of the elbow is gone, eaten away by the root. So that's a nerve graft. It's a sural nerve graft. We took it from the leg. This is a cable graft. So there are actually three nerve graft here. We take one sural nerve graft, and then we make it into three cables, and then we stick it with glue, tissue glue. And then that's how it looks like. So basically we use the radial forearm flap again to cover the wound, and then we graft the nerve. And this is him after the operation. If you can see, he can move his elbow. If we don't do this again, there will be no more function to the hand. And if you can see this, this is a sign of the ulnar claw hand. So that's the sign for ulnar injury. So that's the nerve injury that he had. This was just right after the wound has healed, but the nerve obviously is going to take more time for it to regenerate the hand function. So this is the immediate near short-term follow-up from the flap and also the hand. So this is another patient, a revision surgery. It's a humerus fracture, comminuted. Surgery was done by, you can see her, she's quite a big lady. And when she came and saw me, she had already had two surgeries done. First, the surgeon put in a plate. It broke after a few days. Then the surgeon put in another plate, and it broke again. So
what's the reason?
Not so good surgery, shall I say. So and the patient was told that she had osteoporosis when she was only in her 40s. And she's a big lady. When you are big like this and when you're well nourished like me, you hardly get osteoporosis. That's the That's the good thing about being big. So she was referred to an endocrinologist, and the endocrinologist told the patient, I don't think you have osteoporosis. Please go look for another doctor to fix your elbow. So she
So
came.
basically, the plate broke.
No, actually the plate didn't break. The plate was still intact. It's just that the construct of the plate broke. So basically the plate was not put in a wasn't put in a proper manner lah. So the fixation wasn't adequate. So therefore it broke. So there's not enough stability. So if you don't put enough screws, or the way you put your screws are not right, then obviously it's going to break. So this is her after the revision. This is the plate that we redo this, and this is her after the hand, after the surgery, that she got full range of motion of the elbow. And this is another cock up. This man came to me. This is just recently. These last few cases were all from University Malaya. This is recently, just before the pandemic. This guy fall off a rambutan tree during Hari Raya Haji, and he came to me after some 2 surgeries by another surgeon. Had a very comminuted wrist fracture. You can see ulnar fracture, distal radius comminuted fracture. This was his attempt to fix the bone with 3 wires. And if you can see all this white stuff, they are bone graft, which is not in the fracture site, it's outside. So this is him. I did a revision surgery. It took me 8 hours in the theater to do this. This is not the typical distal radius fracture plates that we put in. These are modified plates. So they are just modification, but this is the hand function 3 months post-op. So that's very, very good. I would say good range of motion after the revision. I just saw him recently. I didn't put up the X-ray, the video, but this is he managed to maintain the good hand function. Another revision surgery, radial head fracture with if you can see the screws are inside the joint. So this is him pre-op. You can see there's no supination at all on this elbow, so that he can pronate, but there's no supination. And if you see this, he's in his 40s. When he came to see me, the wife was crying. He said, "Well, how am I going to feed my family when my husband cannot move his elbow like this? He can't even brush his teeth." So this is him in the theater. If you can see, we are trying to take out the screws there. And the reason why he cannot move his elbow is, if you can see that's a screw inside the joint, in the radial capitular joint. So if the screw is there, it's going to block him from moving. So we took out the plate, we took out the radial part of the radial head, and that's him after we remove the plates. And then this is him with supination, pronation. So that's full. So the thing is, in surgery, right, we can do all these maneuvers, do all this, and then patient can move, but that doesn't translate to outcome if there's no therapy. So that's him. He's bending his head down like this, not because he's shy of the camera, but he is having tremendous pain because our therapist is forcing his elbow, so that we can maintain his range of motion. This is post-op immediately within the first few days of op, and he didn't go back until after about a week, because we wanted to make sure that he could move his elbow. And before the surgery, I told him, I said, look, if you're not going to be able to do therapy, don't do this surgery. I'm going to fail you. So you better want to do therapy. And therapy he did. He stayed for a week. We managed to torture him and got him to do all this. And if you can see, this is 3 months post-op. You can see the supination and pronation. It's not full as in the operating theater, because scar can form after surgery. And this is his elbow flexion.
Oh.
So he can touch his face, he can brush his teeth, he can wash his face compared to pre-op.
So basically, joint fractures are very difficult, right?
Yeah, not easy. No. So joint fractures are difficult to fix because if you don't fix them properly, they will lose function. The patient will lose function, and also you will eventually get osteoarthritis of the joint. So it's very important to do that. So this is another condition that I normally see. This is a duplicated thumb or split thumb. So this is actually, usually we see patients like this as a child or baby, but this was not. This was an adult, and she should be a doctor now. When I saw her, she was still a medical student. When I saw, yeah, so when she came and saw us, she said, "I want my thumb out." So I asked her, I said, most people don't come to us at this age and adults, because most people will be able to live with it and wouldn't want the thumb to be removed. So I asked her, "Are you going to get married or something?" She looked at me and like, "Hello, I'm not I'm a woman, yes, but I'm I also want to do other things. I'm a medical student. I cannot. I want to be an O&G specialist, and I cannot scrub in because I cannot wear gloves." So that was the reason why she came and saw us and wanted the thumb removed. So that's her after the operation. If you can see, there's no more thumb there. But very importantly, when we remove this, the joint must be stable. So it's not as simple as just taking a knife and just cut it off. So we have to make sure that the collateral ligament get reconstructed and stabilized. And so she can. This is just a picture of her being able to do a pinch. If there's no stability, then she cannot pinch. Then she would not be happy at all. She can wear a glove, but then she won't be able to perform any surgeries.
So this extra finger or thumb has its own circulation, has its own joint and its own.
It depends on the type. So there are Wassell classification. It is a type 4. So there are many. There are different gradings to it. Sometimes they come like this. Sometimes they have joint down there. So this is Wassell type 4. So we have to just take out the joint. We have to take out the nerve, the artery, and we have to make sure that we don't simply cut the nerve, because then the patient will develop neuroma at the area that we cut. So all these are things that we have to consider when we take the thumb out. Sometimes the thumb can be very big, so then we make the thumb smaller, and then we put the two bones together and things like that. Yeah.
And if it's a child, what age would be the best age to do this surgery?
Around a year and a half. Because most of the time we try not to do surgery before 6 months because of general anesthesia risk, and we don't want to do them too late because prehension can develop much earlier. So we want to try to do them around 1 year old. And I tell the mom, you don't want to do surgeries when they are at 2 years old, because then they go into the terrible 2 time, and then they will jump here and there. Then they want to use their hands. So when they are about a year plus, general anesthesia is not so dangerous anymore. So the risk is lower, and also it's easier to care for the child before the child go to school and they get bullied by their colleagues at school. So we want to try to do them at about a year plus.
Oh, I had a classmate when I was in primary school who had this. I really wonder why the parent didn't take her for surgery.
Well, there's some religious believe that they are special, and I think certain people think that this is God-given, so why take it out? And most of the time they don't have any function loss, so they actually behave like normal, other than they look different from other child. But most of the time the hand function is pretty normal. So these are not so much of a functional problem, but more of a cosmetic and acceptance problem in the society, I guess. Yeah. So a lot of people will choose not to take it off. So this is my one of the things that we do, microsurgery. Microsurgery is basically just doing surgery under the microscope of or some sort of magnification. So this is a microscope. This is just a photo from the internet. We use micro instruments like this, and we do micro training as well. We now this is a table microscope. You can use loop magnification. We used to kill a lot of rats, chicken, to use their arteries to anastomose to practice on. This is something that I have done. This is an artificial micro vessel. It's a tube. It's a rubber tube with 2 layers to mimic a artificial vessel. So this is 1 millimeter diameter. So we used to use much thicker stuff to suture, but we now can do this. So anyone who wants to learn microsurgery, you can actually set up a microsurgical lab in your own house. So this microscope is actually, table microscope is pretty cheap. This is actually about 600 ringgit only. So you can actually easily afford one of these. But if you buy a surgical microscope that we use in theater, it will cost you a few $100,000. The cheapest you can get is a few $100,000. So it's going to be very, very expensive to set up a lab. But you now can set up a lab at home. So this is what we are trying to tell people that we can do. So again, we're trying to sell this to the world and try to get people to practice, and more we can train more microsurgeons. That's actually the real hand, and then there's the vessel that we are talking about. So you use micro sutures. This is only 9. This is 9O. We have 9, 10, 11O. There's even super microsurgery now where we can anastomose not only vessel but lymph vessels. So you can actually do to drain elephantiasis and things like that. And even for breast surgery and breast reconstruction, the patient who after breast reconstruction, they get a lot of edema in the hand. There are surgeries that's been described very well where you can do transplant of the lymph nodes to help with the edema on the hand. So this is some of the application of what we do with microsurgery. One of the most common things that we do is to put fingers back like this. So this is a 3-finger replant. I took about 36 hours to do this.
Oh my God.
Yep, that was the finger. And that's after many hours of work. We managed to put it back.
How do you, oh my God.
This is this is a hand injury. This is a forearm.
My God.
Those pictures that I shown just now, that was all done in university. This is done in Sunway. This is actually not my case. This is Dr. Ravi, my colleague's case. And I went in and helped him with part of the surgery. We took about 13, 14 hours to do this. So that's the X-ray of the hand. And people always say, hey, are you sure after the amputation and you put it back, the hand can be used? And this is him.
So when you actually do the 3 fingers, right?
Mm-hmm.
And you, of course, you do 1 finger at a time, right?
Mm-hmm. Mm-hmm.
What do you do with the other? How do you keep the other 2 fingers alive?
How to keep the other fingers alive? You try to do it as quickly as possible. You put it in the ice box, keep it cool so that the what do you call that, the tissue don't die lah. So basically to reduce the requirement for the cells requirement. So basically that. So but we know that for fingers you can do replant up to even 48 to 50 hours before the finger die. Yeah. So most of the of course the risk of necrosis is much higher if you if there's a ischemia time of that long lah. So we want to try to put anything back within 6 hours. So yeah, so we can, there are other things that we can do where you put in a artificial tube and run blood into the finger first, but that's 3 fingers and to anastomose yeah, so it's not going to happen now. That unless it is a forearm amputation, yes, you can put in you can just hook up the main artery first, but then when we do that, it will bleed like crazy and patient can get into others. So the forearm, this type of injuries, these are not only problems with replanting, but also this can have a lot of other consequences, like after you put this in, all the dead tissue, you can get renal failure and stuff like that with a replant like this. So people have attempted leg replants and stuff like that, and then patient end up in ICU and die from all the necrotic the dying muscle. So you can get all your, what do you call that? I forget the term now. The muscle necrosis will then, all the creatinine will rise, and then you're gonna have to dialyze the patient post-op.
Oh, rhabdomyolysis?
Yep. Yeah.
Yes.
So this is brachial plexus injury. This is nerve injury.
Sure. I still want to go back to that one, can this one now, when you do the bones first, or you do how do you, the whole hand?
So basically we first, when the patient arrive, most of the time you will get the MO to resuscitate the patient in A&E. As a surgeon, we will take this amputated part to the emergency to the theater and start dissecting and marking where the artery is, where are the nerves. We may even put a plate or wires into this part of the bone. So when the patient, then the anesthetist will go to the emergency department, try to stabilize the patient and get the patient to the theater. So when the patient arrives in theater, we will quickly put this in, plate the thing, and then we want to anastomose the artery, and then then we do all the tendons.
So you work on the severed hand first.
Yes,
while
correct.
waiting for the patient to be resuscitated.
Yes, correct. Yeah. So then we don't lose any time, or else there will be a lot of loss of time, because the surgeon mainly do not resuscitate the patient in the emergency rooms, and we rely on the emergency MO and also our good anesthetists to do all the resuscitative work, so that we can go to theater and start dissecting on this. So in a good perfect setting, you want another or 2 colleagues to come and help you to dissect all this, because there's just a lot of work, and it's not a short surgery. It can last many hours. Yeah. So that was the few years ago. We had a patient a presentation by a Chinese team presenting 10 finger amputation. 10 fingers, so both hands finger was all the fingers were amputated, and they did a 10 finger replant. The 2 surgeons did a 48-hour surgery. 2 surgeons. It was horrible. And then 10 years later, after they developed the whole hand surgery unit in that particular hospital, they had 3 or 4 teams coming in sequence to do the surgery. And they managed to finish the surgery within 12 hours compared to 48 hours. So if you have enough people, you get fresh guys to come in and do every part. So basically, like you said, do you replant finger by finger? Actually, no. We actually replant or reconstruct it by structure. So if you have 5 fingers, you come in, we wire, or we do the bone first, so that we get all the bones stabilized. And then the second team come in and do all the arteries, and then another one come in to do all the veins, and then another team come in to do the tendons and nerve as last. So there are sequence of replantation for this as well.
Okay, from the patient's part, now going to the doctor's part, where you work, let's say 20 over hours, 30 over hours. How do you survive that? You yourself and your colleague.
We collapse after that lah.
How about food and
um, I hardly eat lah. There's no, you can eat lah. I mean, there are people who will break. They will go and eat, take 15, 20 minutes, go eat, go toilet, do whatever you need to do, then come back lah. But most of the time, this happens in the middle of the night. Amputations, they don't come during office hours. They come at 12 midnight, 1 a.m., 4 a.m., and you'll be called, and then you basically go through the whole entire thing like a marathon. So that's why we need good teams to do this properly. And if you are a single surgeon, practice is nearly impossible, because the next day all your patients will be neglected. You will have no more strength to do any other things.
yeah, obviously.
Yeah. So, and all your elective surgeries all be cancelled. So yeah, and you need your colleagues to help you with all those other stuff. The last in Deepavali, we actually did a tongue tumor, cancer tumor. Or we had a plastic surgeon, we had a ENT surgeon, and I went in just to do a small part to hook up the flap. But the whole entire surgery for the patient was more than nearly 24 hours. Yeah, so those are grueling surgery. Yeah, of course. But the amount of effort that we have to put in is like a marathon. It's actually longer than a marathon, because the patient is in the theater for much longer.
Okay.
Yeah.
Thanks.
So this is brachial plexus injury, another bad injury that we can get. This is basically what happens, and if you remember your anatomy, you got a lot of nerves that runs down your neck into the arm, and there's a big highway nerve connections. This is a patient pre-op. If you can see, the patient cannot leave the face not covered. I thought it's covered already. So this is a patient, not playing properly. So you can see she cannot raise the thing. And then this is again, after the operation, we do nerve transfers. So this is pre-op. He cannot extend his elbow. This is after the op. This again, pre-op, he cannot flex the elbow. This is after the op, he can flex the elbow. This is again, he cannot raise the elbow, the shoulder, cannot abduct the shoulder. This is after the surgery. So these are nerve transfers. So basically we find the nerve around the neck. That's one small 1 millimeter nerve that we have to find. That's, again, this is a transfers. Somsak is actually a Thai guy, Thai surgeon. He's my teacher. I learned this technique from him. This is Oberlin transfer. Oberlin is a French surgeon. He's the teacher for Somsak. So they are the one who describe the transfer. So they basically, what nerve transfers means is we take a nerve that is expandable and give it to another to perform another function. So this is just to show you, these are the post-op results, that the patient can actually do what they couldn't do before that. Another thing we talk about, I want to talk about, is hand surgery with local anesthesia. So a lot of surgeries that we do nowadays can be done under local anesthesia. So with the pandemic around, many people are so scared about surgery because general anesthesia is a huge risk, not only to the patient, but also to the anesthetist, to the staff in the theater, to us, the surgeons. Because if you have a COVID positive patient and you put them under anesthesia during the intubation and stuff like that, there's a lot of aerosolization of the saliva, the lung stuff. So these are dangerous for us. So if you can do this under local anesthesia, that will be good to reduce the risk. So why local anesthesia? So we think it's safer lah, because we know that some elderly patients can't be put under general anesthesia because the risk is high. You can get a heart attack and stroke during anesthesia. Again, patient doesn't need to fast. So this patient being hungry is one of those things that nobody likes. And already you are injured, and then now you are made to suffer. You cannot eat, and sometimes if your theater get delayed, patient will be hungry for many hours. And then again, you as a surgeon, you want to see the patient and get them to theater as soon as possible, or else you'll be waiting and waiting and waiting for theater for the fasting time. You can enhance rehabilitation, because when patient can see you repairing the structure or doing something to the hand, and after the repair, the hand can move right away, patient know that you have done a reasonable job and good job, and they will not doubt that you have not done. Because a lot of times when you do a repair or tendon repair, nerve repair, whatever repair you do, they can't see. They don't know. When they wake up, it's all pain and the hand is more swollen than before. So they will be questioning, did you actually repair my tendon? Why is it so painful? But in the theater, if you do this under local anesthesia, there's no pain. If you repair a tendon, they can move right away. And as a surgeon, I can also test whether my repair is reasonable, whether it's good. And of course, it's cheaper, because cost is a big problem for us in private practice, because there's no need for expensive anesthetic drugs. And of course, there's another colleague who has to get involved in the care of the patient, and that costs add to the cost of the surgery. And most of this, because it is done under local anesthesia, you don't need to keep patient overnight in the hospital. So again, that reduces the cost. And that all this is very important, very good thing to do during this pandemic to reduce the risk for surgery. So this is just some of the surgeries that I do under anesthesia. You can see this is a patient pre-op. You can see she cannot extend the finger. This after surgery, you can see right away she can actually extend the finger fully, and then you can show this to her, and she'll be happy to know that she can already extend her finger. So there's a lot of things that we can do. Again, tendon repair. If you see this photo, this is just a small little cut. Again, people should be aware that small cuts like this doesn't mean it's only a minor injury. If you look into the wound, then you will see that the tendon is actually cut. But if you are a GP in the clinic, it's very hard for you to make the diagnosis, and sometimes you can miss this. And if you see this video, I'm going to show you next. You see, he can actually extend the finger. So if you see this patient in the emergency, you think that it's okay lah, it's not cut, so I don't need to send him to the theater, to the hospital, and I just stitch up the wound. All right, and sure enough, when we open up, you can see there's a gap in the tendon. So you just stitch up the wound and send the patient home. This will eventually cause a lot of inflammation and pain. And after you have closed up the wound, if you not debride the wound properly, again, the wound can get infected, and this will not heal. And then many weeks later, patient will come back and say, how come my hand still cannot use, I still cannot use my hand properly? And if you can see, this is nearly fully cut, just a few strands of tendon left that is still attached. Therefore, he can still move the finger, but actually he cannot hyperextend the finger anymore. And this will soon rupture off if you don't repair them. So that's why it's important to explore this and repair them. And this is, again, after the repair, you can see I'm testing the repair and making sure that the repair, you can see the tendon is gliding and it's not gaping, because if I don't repair it properly, you'll gape and you will open up. So flexor tendon repair, same thing, small cuts like this. You can see that's the tendon there, that's the nerve artery at the sides. And that's the repair. And this is again testing the repair. So you can see this is the repair there. So you can test your repair right away. and patient will be happy. Hey, before operation, I cannot move my finger, now I can. So that's my last slide. Any question? Anyone want to
So this
ask?
under
Yeah.
local is given by you, the local?
Yes, most of the time I do my own local anesthesia. I because this nerve either wrist block or finger block or digital block. So we know how to do that. So there is another way of doing this. It's called Oberlin surgery or wide awake local anesthesia no tourniquet surgery. If you can see here, this is a finger surgery, and you can see this artery here that the finger is very wide. That's the tourniquet in the finger. So there's a
I see.
big movement now to say that we don't want this tourniquet. So I give previously when we do local anesthesia, right? We give anesthesia for the hand and the fingers. We don't want to use adrenaline or epinephrine because there is some study to show previously that if you give epinephrine to the fingers or end arteries, the finger can die, it will necrose off. So now there is a movement away from that to say that I can still use epinephrine for finger injuries like this. So they will give injections around here, local anesthesia with epinephrine. So we don't need to tie this down. So the epinephrine will stop blood flow to the finger or the wound, but the main artery will still have blood flow, so the finger will not necrose off. But I don't believe we need to do that because we can easily put a rubber band like this, and we can still complete the surgery without using the epinephrine. And although there is some, the statistic shows that the finger will survive even with the local anesthesia, there are some studies, there are some people who reported using that technique and then the finger actually necroses off later. So for me, unless you want to take the risk and you know that you can be very sure that the finger is not going to die, you need to have a conversation with the patient, because I think just putting a small little rubber band like this is not a problem at all. When I was training in university, we were banned to do this because someone forgot to remove this and send the patient home with a rubber band around, and then 3 days later the patient turned up and say, how come my finger is black?
Oh my God.
Yeah. So what they did was they didn't use an artery like this. They just put a rubber band around it and and they forgot to cut the rubber band after the surgery. So they repair the tendon, do whatever they need to do, but they forgot to release the tourniquet. So 3 days later, the patient came in with a necrotic finger. And so after that, we got banned in the university from using it. But I remember very well as a young as a high school student, when my ad maths teacher, there was a ban from us using liquid paper to in the school because people were using liquid paper to chonteng all the tables and chairs and walls and whatnot. So the school banned us from using liquid paper. And my school teacher made this ad maths teacher made this funny joke that if Spider-Man, Superman, and Madonna doesn't know how to wear their underwear, doesn't mean that all of us shouldn't be wearing the underwear as well. So same thing for me. This is just a tool. This is a technique. As a surgeon, as a healthcare workers, you must know there are many techniques, and all the techniques comes with some sort of risk, and we must take a lot of care and a lot of attention to what those risks are, and take steps to prevent it from happening. I mean, this is a good technique as long as you take it off. If you don't take it off, of course, it's a bad technique. So don't blame the technique.
True.
So we must utilize all techniques possible to treat our patient the best we can, and not say this technique is very bad and so therefore we don't use it at all. Yeah, that's negligent. That's totally negligent. Yes. And banning the technique is not going to stop another person to use it next time. So it's more of educating people and telling people that you can use this, but these are the problems, and look out for it and make steps to prevent it. All right. Yeah, that's
okay, can you stop sharing? I want to share the QR code.
Sure.
Okay, let me just share the QR code. Safari, hold on.
Is this for the CPD
Yes,
point?
this is for the CPD point. This is what. Okay. Oh, what is wrong? Hold on. I'm so sorry. Yeah, this should be fine. So this is what I want to share. Safari. Let's see. Oh, how come it's not sharing this one? Okay, this is.
Yep, it's up. I can see it now.
You can see it?
Yep.
Okay, great.
But I don't know how to scan it.
You have to use the okay. You can see it, but I can't see it. So sorry.
Now it's not there anymore. Now it's just your desktop.
Just my desktop.
Yep.
Something is not right. Huh? Okay. Is it there?
Now it's now it's up.
Okay, hold on. Okay. Okay.
Yep,
So
now-
basically, you can only scan it using your MMA app if you use the laptop. Okay. So you use your handphone to scan it. Whoever cannot scan it can actually then message me on WhatsApp. This is my number. I'm going to give it to you. Give me your name, your IC, your MMC, and your email address. Okay. Is there any questions? I will stop the recording now. Oh no, resume. How do what happened? I can't stop recording. Any questions at all?